Hey everyone, welcome back to The Explainer. If you're a radiation oncology resident, you already know the incredibly high stakes when it comes to spinal SBRT. Today, we're diving into some absolutely practice-changing data from a 2025 paper by Dibbs and colleagues, published in Radiation Oncology. We're going to look at exactly how to predict vertebral compression fractures, or VCFs, following spinal stereotactic body radiotherapy. This is essential stuff for your clinic, so let's just jump right in.
Picture this. You sit down at your workstation to contour a spinal target, right? And you're instantly hit with that classic clinical dilemma. You want to deliver an ablative dose to get maximum tumor control, obviously, but you've got to protect the structural integrity of the patient's spine at the same time. SBRT is an amazingly precise tool, but it introduces a major wildcard. How do we know which patient is actually going to fracture?
To really grasp the gravity of this, let's just look at the baseline numbers. With conventional fractionated external beam radiotherapy, the risk of a VCF hovers around a very manageable 5%. But when we escalate to spine SBRT to improve control, that risk absolutely skyrockets. Depending on the series you look at, you're facing an 11 to 39% risk of a fracture. That is a massive complication rate to accept for a patient who is already dealing with metastatic disease. So here's our roadmap for today's explainer. We'll start with the SBRT complication dilemma, look at expanding the risk profile, break down the 4 predictive risk factors, walk through the actual VCF predictive nomogram, and finally cover the clinical actions to mitigate this risk. Starting off with Section 1, the SBRT complication dilemma. Now, from prior literature, we already know a few established risk factors for VCFs, things like a GTV over 10 cc, lumbar location, epidural extension, but one of the absolute heaviest hitters is end plate disruption. Just as a quick refresher, that's the cortical disruption of the superior or inferior vertebral end plate by the tumor itself. When you're doing your targeting and drawing up your GTV on those pretreatment CTs, you really have to scrutinize the integrity of those cortical end plates. Which brings us to Section 2, expanding the risk profile. So how does the 2025 Dibbs paper build on what we know? Well, they looked at an expanded retrospective cohort from a single high-volume institution. We're talking 173 spine SBRT patients treated between 2013 and 2020, with a median age of around 62. And what they found is pretty striking. 17% of these patients, that's 30 out of 173, experienced a VCF. And get this, the median time to fracture was just 4.8 months post-SBRT, so we're talking about a very early severe toxicity here. But here is the real kicker. While older cohorts definitely looked at end plates and SIN scores and histology, they kind of missed a massive piece of the puzzle: chronic steroid use. In this dataset, they specifically defined chronic steroid use as 4 weeks or more within a window of plus or minus 4 weeks of the SBRT. And honestly, this turns out to be a total game changer for predicting fracture risk. All right, Section 3, the 4 predictive risk factors. You're definitely going to want to remember these. When we dig into the multivariate analysis, the independent predictors of VCF are just glaring. The hazard ratios here are staggering. End plate disruption? That carries a hazard ratio of 4.16. A SIN score of 7 or higher gives you a 3.63 hazard ratio. That chronic steroid use we just talked about, 3.60. And adverse histology sits at 2.98. I mean, just look at how powerfully end plate disruption and chronic steroids drive this risk. These aren't just minor correlations, guys. They are massive red flags. So let's distill this into the 4 pillars of VCF risk for your daily clinic, and let's be real, for your board exams. Pillar 1, end plate disruption. Pillar 2, a SIN score of 7 or greater. Pillar 3, chronic steroid use for 4 weeks or more. And Pillar 4, adverse histology. Just a quick note on that last one. In this specific study, adverse histology meant non-small cell lung cancer, breast adenocarcinoma, and anal colorectal cancers. Moving right along to Section 4, the VCF predictive nomogram. The true beauty of this nomogram is just how ridiculously simple it is. It's literally a 0 to 4-point scale. You just assign exactly 1 point for each of those 4 risk pillars we just went over. Does the patient have end plate disruption? 1 point. Are they on chronic steroids? 1 point. It's so straightforward, you can calculate the whole shebang in seconds while you're reviewing the chart. And you can really see the power of this simple scoring system when you look at the data mapped out. Looking at the 1-year cumulative incidence of VCF, the separation between these risk groups over time is immense. The low-risk group stays relatively flat down at the bottom. The intermediate risk group starts pulling away in the middle. And then that high-risk group, it climbs super aggressively right there in the first 12 months. The stratification is just undeniable. Let's put some hard numbers to that to really put it into perspective. For low-risk patients, meaning they score 0 or 1, the one-year cumulative VCF incidence is a very manageable 2%. If they hit the intermediate tier at exactly 2 points, that jumps up to 21%. But check out the high-risk group. If your patient scores a 3 or 4, they are looking at an enormous 58% risk of a vertebral compression fracture within 1 year. That's literally worse than a coin flip that the radiation treatment will lead to a structural failure of their spine. Which leads us to our final part, Section 5, Clinical Action, Mitigating Risk. We really need to talk about what a VCF actually means for these patients. In this cohort, out of the high-risk group, 62% developed a fracture. And to be clear, these were not just silent asymptomatic findings on a follow-up MRI. Every single patient who developed a VCF required opioids. 4 of them ended up in the ED for uncontrolled pain. 2 needed vertebroplasty, and 2 actually required decompression and instrumented fusion because of spinal cord compression. Failing to anticipate a fracture here leads to severe, real-world morbidity. So, what's the ultimate clinical takeaway here? The authors lay out a very clear recommendation. High-risk patients, again, those scoring a 3 or 4, should absolutely be considered for upfront prophylactic vertebral augmentation. Because their 1-year fracture-free survival is a dismal 29%. Identifying these folks before they ever get on the treatment table is absolutely crucial. It lets you refer them for preventative interventions, like cement augmentation, to stabilize the spine and avoid those devastating consequences altogether. So I want to leave you with a thought. When you sit down for your very next SBRT contouring session, how are you going to evaluate that patient's spine? Are you just going to draw your CTV, or are you going to actively look for end plate disruption? Calculate that SIN score, check their chart for a 4-week history of steroids, run those 4 points. It takes maybe 60 seconds, and it might just save your patient from a catastrophic spinal fracture. Thanks for hanging out with me for this explainer. Keep learning, and I'll catch you in the next one.